Okay, tonight, everybody, we are talking about the new treatments. And what I particularly want to look at is what are people's goals for themselves, for their spouses or partners, for their children, and not only what are your goals, but also how are you best going to achieve them? Are they sensible and realistic? For those type 3s who are still not eligible, what are you doing now for when these drugs do come? Because if you haven't been doing any exercise for a long time, if you haven't had any stretches, if you haven't put the effort in with your arms, where are you going to be when you are eligible for the drugs? So I think we need to think about a lot of things when we're talking about the drugs, even for those who are on them. What are our expectations? What is sensible and reasonable? What can you expect in the way of help? And what should physios, whether NHS or private, be doing to help you? And these drugs by themselves do not just work magically. They will not improve power. They will help with chest infections because they will help to stop deterioration in your chest, might make you stronger in your trunk muscles, help your breathing. They may well help your speech. We certainly know that several of the children with quite difficult speech, low volume, low power in their speech have improved. And that's all part of head control, throat control. So there are things that the Spinraza is doing without any intervention. If you're already having cough assist, if you're already on BiPAP or your child is, and it's improving your breathing, you're not actively doing something to help. The Spinraza or even the Risdiplam is helping by improving respiratory muscle power, improving some swallowing, and improving speech. And speech and swallowing often go together. So there are things that can improve without any input whatsoever. But the question is, what are the goals? If all your goals or the goals for your children are to prevent deterioration, are to maintain good respiratory function, reduce your number of chest infections or stop chest infections, but you cannot do that without some respiratory input from respiratory physicians, possibly respiratory physios. If that is your only goals, then those drugs should help without any extra intervention. But if your goals are bigger than that, we need to think about where we're going, what's realistic, what is sensible, and what can you do based on the condition you're in when you start the treatments. So if we look at the smallest children at the moment, we know that virtually all of them are on either nusinersen or some of them are being swapped over to Risdiplam, and most of them are making good progress. But it's very obvious that the stronger you start, in most cases, the more gains you will experience. So the strongest of the type 1s are making the biggest gains. The type 1Cs are the children who are sitting, are the children who are standing effectively in orthotics, some of whom are taking steps, some of whom are actually now standing independently, although none of them are actually walking independently without help. And those are our current type 1s in this country, unless you were treated pre-symptomatically or very, very young. The weaker children are not having as many gains. They're having the same gains in terms of respiratory, but do not think for 1 minute that everybody who's on Risdiplam or Spinraza is not having chest infections, is not being admitted to hospital. It's not some wonder cure. We are still seeing children in intensive care units, in hospital with chest infections. Admittedly, many of the 1Cs do have really quite good respiratory reserve and are avoiding the chest infections, but the weaker children are not. Some of the weaker type 2s are not. We have one little type 2 at the moment who's really very unwell, even on nusinersen. So it's not a cure. It's not going to solve every problem. So what we need to think of is, where is it going to help? And how can you best help yourself or your child? One of the big issues with the type 2s and non-ambulant 3s, although we admit the 3s, non-ambulant 3s aren't getting it, is contractures. These drugs will not cure contractures. What we are seeing with a lot of physio input, and that I'm not talking about necessarily from a physiotherapist. Physiotherapist and physiotherapy, as we've discussed before, are not the same thing. Any input that a parent makes that is relevant, that is exercise, that is activity, even the correct sort of play, is physiotherapy. Every time a parent, when a child says, sit me up, roll me over, when they ask the child to at least attempt it for themselves, is giving them an opportunity to exercise. And these are all the things we need to think about. And it's not unreasonable to write out what your goals are. Is it to roll over in bed? Is it to be able to do your own hair? Many, many people will not get to that level of doing their own transfers or being able to stand, possibly walk. But the question will always be, how much will I gain if I really push myself, and how much will I gain with nothing? You are asking for two things. Firstly, a very expensive drug, but that's not the issue. The issue is you are going through a lot of treatment. Intrathecal injection, it's not the most simple thing in the world. You are talking about having an injection into your spine. Many people do have problems of scoliosis, spinal surgery, continued spinal difficulties that will make having Spinraza difficult. And we know that some are going on to risdiplam. But that is not common. I'm not even going to talk about Zolexma because I don't think it's relevant to what we're really talking about. I think that those few people who've had the injection are having lots of input. I think that you do still need lots of physiotherapy to make gains, and you still need the input. And there are some children who've had the injection and are now going on to other drugs. So again, we're not looking at cures. We are looking at improvement. We are looking at not deteriorating. But to counter that, we have to think about the downside, and there are downsides. One of the big problems we're seeing with type 1 is a lot of scoliosis. So most of the children are developing scoliosis, and we know that one of the big issues with scoliosis, even just in the UK, and we can only really talk about the UK, is the very, very variability, both in terms of management from the orthopedic and surgeon point of view, and from the orthotics point of view, those surgeons who feel that spinal bracing is helpful. Many surgeons don't feel spinal bracing is helpful. And there's a spectrum of ideas in between, and this causes conflict. So we have quite a lot of conflict, and it's something that I'm happy to take questions about, is scoliosis and the management of scoliosis, because definitely, although it was always something that was there in terms of type 2, it's obviously something that's become very much bigger in type 1. And the other big problem that we're seeing with these drugs is the increase in contractures. Because if you are improving power, and if your stronger muscles are the ones that are going to get strongest, then obviously the muscle imbalance will increase. So we have to think that it's all very well getting these drugs, stopping the deterioration, but are contractures going to get in the way? And some adults will say, well, contractures don't get worse once you're an adult. They can. Your muscles can still get tighter when you're an adult. I know people who've said that their hands have got tighter, particularly their forearms have got tighter. And while you won't get the contractures increasing because of the increased bone length, and that's what happens during growth in children, as the bones grow longer, if the muscles aren't stretchy enough, you'll get contractures. But we have postural contractures, in other words, sitting in the same position for long periods. If you're not standing, if you're not changing position, then you will get increasing contractures. If you're not using your arms, if your hands are continuously palm down, then you will lose the ability to turn them palm up. You will get tighter elbows. And as you get older, and people miss this because they just assume it won't happen, you can get tighter shoulders as well. The shoulder is quite a complex joint. It's not just about the arm moving up and down. There's a whole range of movements around the shoulder blade, and those movements can get tight. So if your shoulder blade doesn't move on your spine because the muscles are tight around your shoulder blade, then it's going to restrict the movement of your arm. You're going to find your shoulders are pulled up towards your ears, which again causes problems when you're trying to move your neck. So there's knock-on effects of increasing contractures. And we know that despite people saying that SMA is not deteriorating, that the initial whatever trauma or whatever happens to the nerve cells happens when you're little, we know many adults do complain about deterioration in their upper limbs in their 20s and 30s particularly. Now, the norm is for muscle to deteriorate with age. All of us, muscle will somehow deteriorate as we get older. There are very few 70, 80 and 90-year-olds who could weight lift or do headstands or gymnastics or whatever. There's the odd one that you see on Facebook, which is incredible, but the general population are not as strong once they get past 40, 50 as they were in their younger years. And this seems to be more apparent in something like SMA, where there's muscle weakness. And obviously, with improved respiratory, we are expecting to see many, many more type 2s living into their 70s and 80s. And you don't want to be so incapacitated by muscle weakness that you can do very little, because that's not life, that's existence. Marnie, have we got any questions so far?
Yeah, we've got a few. First one is, my daughter is getting stronger, but her legs are getting tighter. How do I counteract this? Seems horrible. The body gets stronger, but the limbs are too stiff and bent to be used.
Well, this is what the whole issue with the contractures, and we have seen this over and over, and it really is so important to do two things: to think about positioning and to think about stretches. Now, stretches by themselves will never ever be enough. Even if you stretched twice a day your hips and your knees, if you're sitting 15, 16 hours a day, then obviously that is the position that you're in, and that's the position your muscles are working in, and it's really difficult. Standing, if you can stand to give them a stretch, is a very effective way of doing it. You can have splints for your knees, but you have to consider the position your hips are in. The problem with knees and hips is when one gets bent, the other will bend as well. You cannot have bent hips without bent knees, and the other way around. Let me get my creatures. I have to say, I have a new Ike. I don't know what we would call this one because it came from Tiger. So Ike was from IKEA. But the problem that we have, as I say, is that when you have a bent hip, even if you're lying down and your hip bends, it's very hard for your knee to find somewhere to go. Because if your hip's sticking up in bed, your knee's going to either bend or roll outwards to lie down. And when it rolls outwards to lie down, it's still going to be bent. Nobody rolls their leg outwards completely straight. So that the problem, as I say, is once your hip is bent, your knee needs to bend to go somewhere. And the other problem is exactly the same. If my knee is bent, my hip bends, and that needs to go somewhere. So you can't really talk about hips without knees and knees without hips. This is a problem. And unfortunately, that makes standing or lying flat one of the best positions. However, lying flat is not very functional. You can't do a lot of schoolwork or computer work when you're lying flat. So then you have to think about standing. And if you already have contractures, standing can be quite difficult. If your knees and hips are already bent, finding a standing frame that is comfortable to stand with your knees and hips bent, so that you're not just getting a lot of pressure over the knees and you don't have to push the bottom in tight and you don't end up with that big arch in your back because of the hip tightness of your hips. It's quite difficult. The best that we can do is try and minimize that tightness. And that's where we need to go. But it's a positioning job. It may be an in bed at night job. It's really tough to ask children to wear night splints on their feet and their knees, to use sleep systems, which I know a lot of parents find extremely difficult and the children find very hot. But if you need turning at night in bed, a sleep system is a bit of a nightmare, because when you want to turn, you've got to change the whole sleep system over. But you need to make compromises. You need to think about standing. It's the only position where your knees and hips, apart from lying, as I say, can be made as straight as possible. You can't do it in sitting. You absolutely can't do it in sitting, because even if you sat with your legs out straight, you're still going to be bent at the hips. It's about position, it's about stretches, and it's about active stretches. And we've said this so often, active stretches are when the child's doing some of the work. So if I'm trying to stretch a knee, then the child has to be trying to straighten. And this goes for adults as well. This is not just about children. It makes no difference if they cannot actually lift it. The important thing is they're trying, because by trying, they're relaxing the muscle at the back of the knee, and that gives you a better stretch. So it's all about active stretches, positioning, standing if you can, lying, good lying position. But lying is not a functional position, and not unless you have a computer on the ceiling or something that's going to help. Lying is not functional. It's a good place to try and get as straight as possible, but it's not a functional position. Now, the other thing we have to avoid is those activities and exercises that are just going to strengthen those muscles up. So the ones that strengthen your hip flexors, the ones that strengthen your knee flexors, and the ones that strengthen the pointy down of the feet. And the pointy down of the feet, everybody seems to know about. But the ones that bend your hip, the exercises that so many physios do, that end up bending these hips. And this is where we get a lot of problem, because a lot of physios just do not see that what they're often doing is just encouraging these hip flexors with some of the exercises. Resisted crawling, some of the spider cages, some of the exercises with kicking, a lot of things we've got to try and avoid using overworking these muscles. And that's another important thing. So to do that, we have to think about alternatives, moving the legs apart and back together when they're straight, trying to work the butt muscles, which I know is difficult, but again, it's a case of put them in the best position to do it. And that is often in lying with TheraBand going backwards, not just forwards, backwards, taking the leg back. You can bring it forwards and then take it all the way back. Using TheraBand, using activities, swimming, which unfortunately at the moment is an activity that not very many people are able to access. but think about the exercises that you're doing, the activities you're doing, the sport you're doing, and whether it's increasing the work at the front of the hips, because that, again, if it's exercising those muscles, will just be increasing the problem. Marnie.
Yeah. Next question is, a farmer is going to work with local physios in educating and doing programs, as this is now about rehabilitation.
It is generally about rehabilitation, but again, we need to set realistic goals and aims. We can't talk about rehabilitation in terms of what is rehabilitation. It is restoring, admittedly, but restoring to what level? Restoring movement, restoring power, restoring function, restoring ability, but to what level? You can't just say you were type 3, you're 25 years old, you stopped walking at 12, we're going to get you walking again. We can't say you're a type 2, we're going to get you crawling again when you're 36 years old. You used to be able to crawl when you were little. Are we going to do that? Is it realistic? Is it functional? It is rehabilitation. Now, it doesn't mean to say that we'll get any more physio out of any authority, but it is, and we have to think, but we have to think sensible. We have to think goal orientated. What do we want to achieve? Do we want to achieve high kneeling at 36 years old, or do we want to achieve rolling over in bed, or being able to sit ourselves up in bed if we don't have a bed that will sit us up? Do we want to be able to reach things that we've dropped out of the wheelchair? Do we want to be able to put the harness on the dog ourselves? One of the scales that we use for SMA is called the EK scale. It's a scale that was developed in Denmark. It's available on the internet. You can see it. And one of the nice things about the EK scale, it's very, very functionally orientated. And if you look at the scale, it may give you, particularly adults and teenagers, it may give you some ideas of the goals you would want to achieve, because it will give you an idea of the next level of function to where you are. So that if it looks at rolling over, if it looks at standing, it looks at the ability to move around in the wheelchair. Can you lean forwards and come back up again? Most people can, but not everybody can. Can you lean sideways in the wheelchair? Can you functionally open that Coke bottle? Can you open that crisp packet? So if you're looking for functional goals and you're not sure where you want to go goal-wise, the EK scale is quite a nice functional scale that may give you some ideas of what to work on with your physio if you're seeing one. I accept many adults will get minimal physio, irrespective of the fact that the health service is going to pay a lot of money for a drug and won't pay a lot of money for physio. But I'm afraid that's the state of the nation, and it's not going to get better. So we've got to think about putting a lot of effort in ourselves, trying to work ourselves, trying to motivate ourselves. It may even be that one of the best ways to be motivated is to try and set up Zoom groups, to try and find a group of type 2s in their 30s who are all going through the same thing at the same time. We don't know how we're going to motivate each other. But it may well be that we need to set up groups to do this, to support each other, to give each other ideas, to motivate you, particularly if there are times when you don't feel the drug is working so well. So we need to think that this is not going to be given to us that easily, and that it is rehabilitation, but we may have to do it in a different way than actually expecting it. Now, there is only 2 centres that I'm aware of that will do rehabilitation with adults. There is the Neuromuscular Centre in Winsford in Cheshire. If anybody can access that, that is a very, very good place to go and get some help. There is another one in Coventry, I'm not sure that that is as accessible in terms of neuromuscular disorders generally as much as Winsford, but those are pretty much the only centres in the country that are specific to neuromuscular, which is very difficult. But then for children, there's no rehabilitation services, there's no centres for rehabilitation at all. So again, it's really trying to mobilise your local teams. SMA is not common enough to have groups where you could all motivate each other, but again, it might be worth linking up and trying to get a physio to bring people together and get yourself motivated. It's like slimming classes. Some people say it works better if they go to a class because they get more motivated, they see other people, and it might be that this is the way we need to go, that we need to do it in groups, get like together, and get everybody motivating each other.
Okay. Next one is, at what stage do I start removing support as my son gets stronger? Sorry, I've just lost it. Like headrests. I do not want him to have the support if it is not needed. It is also hard to explain this to local physios.
I think the first thing we need to know is how old. And the second thing we need to know is at what level, because if we're talking about a type 1, it's really a case of slowly. If they're very little, there's things like the squiggles system, which is really lovely because the squiggles seating system is very modular and you can put a bit of headrest in and then remove it for a little while and put it back. One of the troubles with seating is it's a seat that is fitted to the child at a particular point in time, and when they become stronger, it may be that it's no longer appropriate because it's giving them too much support, and I accept that is a problem. But the other thing we have to think about with SMA is fatigue. And this is why whatever you do, you have to do it slowly, a little bit at a time. So that the squiggle seating system, but it only works for littlies, this little modular seating system where you can do it bit by bit. So you've got a little piece you can put behind the head, and then you can take it away for a couple of minutes, put it back, take it away. You can tip them, you can take the sides away, you could bring their legs together because there's a mat where you Velcro all the bits together so you can hold the legs in, take the thing away. It is difficult to be able to decide at what point you reduce the amount of support. The other thing is standing. I know I'm not popular with some physios because I believe all the children should be standing in something, whether it be a tilt table, which is an easy thing to stand on, or whether it even be in gaiters or CAFOs, that children need to stand for lots of reasons. It gets weight through their bones, it helps with the contractures, it gives them a different perspective, it gets the weight off their tushy-boo for a point in time, because let's be honest about it, if you spend all day on your tushy-boo, it does get a little bit numb and a little bit worn out. Doesn't mean to say it gets smaller, unfortunately, but we need to take the support off in standing. So it's no good putting a child on a tilt table or supine stander, as they're also called, and then just leaving them there forever when they're getting stronger and stronger. You can bring it higher up to standing, but that's not taking away the support, that's just changing the angle. You want to give them less support around the trunk, you want to give them less support at the head, and you need the physio to appreciate and challenge the child without fatiguing them, because if you fatigue them, then you lose them, and then a physio who has lost the child through fatigue may think that they're too weak to keep going. And this is the balance that physios need to understand, that sometimes if you over fatigue the child, they can't do it, and then they think, oh, well, they're just too weak. And that's not true. Little and often, don't fatigue them, give them time to perform, give them a lot of space, try different positions. You may not be able to do something in sitting, but you may be able to do it in lying. You may be able to change the position. You may be able to do something in side lying that you can't do when you're lying on your back. You may even get to the point where you go over a ball and work over a ball and take the support off by bringing them forwards or taking them back on the ball or the peanut. So a peanut or a ball is a nice place to challenge and see what a child can do. So there are lots of ways of removing support. We need, and I know we've talked about this before, we need to get this all written down, but there's so much that we could write down. One of these days we'll get this book published. It's there, it's sitting waiting, but we need to think, physios need to think how to challenge these children. It's very, very different challenging an SMA child to challenging a cerebral palsy child. It's so incredibly different that many physios don't see it in SMA, and they just need that practice and experience.
Okay, thank you. The next question is, how do I engage muscles in order to wake them up?
That's a really interesting question. There's lots of ways of doing it. We can use taping. We have used taping to wake up muscles. It can stimulate muscles, but you need somebody to help you learn to tape. You can use electrical stimulation to help wake your muscles up, particularly if it's something like straightening your knee. It's maybe not as effective on your butt muscles to straighten your hips, because it's, if you think about the amount of work that the muscles have to do to lift your hips up, it would be incredibly difficult, but it can be woken up with electrical stimulation. As I say, you can use taping. You can actually even use massage to stimulate the muscles, but it won't wake them up in as much as massage will not make them work harder, but at least it will give them an idea of what they're supposed to be doing. But resistance, a physio using resistance, PNF, which we have talked about before, which I will quickly say is proprioceptive neuromuscular facilitation. Forget it, it's PNF. That is a very good way of waking muscles up, but you do need to have a physio who's experienced in PNF. That's not the easiest option, but I do think taping or electrical stimulation can certainly wake up some muscles.
Okay, if a certain muscle has never worked, how do I activate them? For example, my arm is limp. How do I start moving it if there's nothing there at all to engage it?
It's interesting you say nothing there, because there's many people who think there is nothing there because they're not using the correct positions. Very often when we use the TheraBand, I'm not sure if I've got any here. When you use the TheraBand to take the weight of the limb, very often you can use the arm a lot more than you think. So that what we find is, but by using the TheraBand to suspend the arm, then you will get movement. It's the weight of the arm that is so often the problem. It's not the lack of muscles working. Very, very few muscles, particularly in a type 2, are completely paralyzed. They are just so extremely weak that they won't produce a movement. That doesn't mean to say that they're not there, they're not working. We just have to put the movements in the right place. So in the same way that you may not be able to bend your hand up towards your mouth, the same movement may be, and we've said this again and again, if you've got a board that you could slide it on, backwards and forwards would be a good way of starting. And what we call them is movements without the effect of gravity. So you're not fighting gravity. If you have normal movement, you don't think that gravity is pushing down on you the whole time, because the effect of gravity for somebody without a movement problem or bits of body that move against gravity think nothing of it. But the effect of gravity when you're incredibly weak are enormous. So we have to do movements where we take away the effect of gravity. So if I am bending and straightening my elbow without gravity, then I am sliding it. I can slide my hand backwards and forwards. It may seem banal, it may seem unhelpful, but it's a way of getting there. Get a sliding board, a piece of cardboard. chop up one of your Amazon boxes, because I'm sure all of you have had Amazon boxes arrive during lockdown. There isn't one person out there who hasn't got an Amazon box they can't chop up and use to slide, slide, slide. It's a good way of starting. Sliding your arm backwards and forwards, sliding your elbow in and out, sliding your fingers backwards and forwards. So many things you can do. It's very hard to slide your trunk. It's big, but you can slide your legs. So you can put your legs on a big piece of cardboard and slide them in and out. Not so easy backwards and forwards. You do need to use the TheraBand for backwards and forwards, although you can put one leg forward and one leg behind it and try sliding backwards and forwards that way. So there's a lot of things you can do to switch these muscles on, and they probably are not as weak as you think. Even the tiniest twitch can be worked on.
Okay, another one is, should I exercise daily?
Afraid so. The answer to that is a simple yes. The big problem we have with exercise is it is cumulative. The more you do, the better it's going to get. If you exercise every single day for 6 weeks and exercise quite hard, the aerobic exercise, you gain something, you know, all of those of you who've done exercise, your 6 week block of hydro, it might make a difference on the day. It might make a difference for a couple of days. It's cumulative over 6 weeks. It may help. You know, when you go on holiday, you every day in the pool. Every day in the pool on holiday, you've gone to your wherever, to Greece or Spain or somewhere, you've swum every day in the pool, you're 100% fitter. Come home 2 weeks later, it's all gone because you haven't capitalized on it. One of the first young men I ever treated with SMA, his family lived abroad and he spent 6 weeks every summer. He was a type 3 who'd lost ambulation. He spent 6 weeks every summer beside a pool. Used to get in the pool on the first day, he had to be hauled out. By the end of 6 weeks, he could get himself out, and he'd come home 6 weeks later, that had all gone. He hadn't exercised, he hadn't capitalized on that exercise in the pool. And 6 weeks later, he said, you know, he couldn't do his own transfers again. His arms had just lost it. And he knew he should have capitalized on it. He knew he should have maintained that exercise level. He knew that he would have benefited from it, but he didn't do it. He wasn't motivated. It's great when you're on holiday. It's great when you have time. But the problem often with the idea of exercise daily is it becomes a chore. I've got to do my exercise now. If you can build that exercise into an everyday routine, if you can do something, if you normally have somebody lift you into sitting, if you try, even if you don't achieve it, if you think, I'm going to try and get myself into sitting, I'm at least going to try and roll myself over, that's at least a start. Then there is something else you could be doing. There is do something in the kitchen. You know, one of the things I said during lockdown, go and bake bread, go and do some baking, don't switch the mixer on, go and do some hand whisking. I'm not saying you need to get one of those old fashioned whisk things, but go and do some work, go and have fun in the kitchen, do something constructive and positive, and you won't feel that it's exercise. But if you increase your activity levels, if you make yourself a plan for every day of a different activity, go change the duvet cover, that'll kill you. Go try making your own bed, that's going to be exercise for your arms. How many people are going to absolutely find that impossible? But you never know, with a bit of help and a bit of practice, you may even be able to change your own duvet cover, or certainly your own pillowcase. Give your pillowcase a go for starters. That's a good one to start with. If you can't do the duvet cover, have a go at changing your own pillowcases. That's exercise. It's a start.
Okay.
Giving you an idea there, Marnie, haven't I?
I think I'll leave that one to my mum. If you're doing makeup, that's exercise enough for me.
Okay, well, that's good enough.
Next question is, SMA type 2 is looking to start standing again in a standing sling, but is worried about their osteoporosis. Any advice on that?
A standing sling shouldn't, in theory, affect osteoporosis. If you are normally in a sling for transfers, there is no reason why a standing sling should make a problem. What will cause the problem is the weight bearing. So it depends just on how much you are able to weight bear. Now we need to get real about this. Most people with SMA2 who are going to have standing slings, and several people are going for standing slings as a way of improving their position, their posture, their exercise, you're going to have very tight hips and knees. You are not taking a lot of weight through your legs. The sling is doing the vast majority of the weight. So you're in a standing sling, you've got bent hips and knees, you're being held up in this sling. And even if your feet are on the floor, unless you are really working hard, unless that sling has got you almost crunched up, you are not going to be taking that much weight through your feet. I don't think, unless you are prone to micro fractures. Now that is not common, but there are some people out there, and I know some very osteoporotic type 2s who have micro fractures, and that's particularly around the knees. And you will know if you are one of those people because you tend to get quite painful knees, particularly when they're moved or if they're stretched. It's not common. I am not talking about the normal stretching, uncomfortable feeling of stretching. I'm talking about true pain, even pain at rest. And we know people who do get that pain. Now, that can be helped if you are standing by having some sort of splint. And the easiest splints would be soft cast splints. The problem we have is many physios say, oh, we can't make soft cast here. Soft cast is the easiest thing in the world to use and to do. It really is not a problem. I can't believe that any physio could not make a soft cast splint. What they might not be able to do is get the materials. But we teach soft cast splinting in a way that could be done in anybody's home. You could literally, with a bowl of water and the splinting materials, make a pair of soft cast splints. Actually in the home, it takes 20 minutes to make a pair of splints. That is it. And that would help protect the knees if you were really worried about your osteoporosis. But the easiest way to make sure that your osteoporosis is not affected by standing is just to make sure you don't put too much weight straight away. So you don't have to have the sling putting you in a position where you're taking too much weight through your feet initially. Start off with just a little bit and then gradually increase it. You will know if it's causing a problem, if it's painful or uncomfortable. And then again, you should be the one with the control in your hand. You should not be letting anybody else hold that control. So as long as you can press the buttons, you should be in control of that hoist mechanism thing, because you're the best person to know whether that is uncomfortable.
Okay, someone's just added on to that question about the same thing regarding stretches, and they're worried about their osteoporosis within stretches.
Okay, now the main thing with stretchers, and I can't say this often enough, if they are active, they are much less likely to cause damage and pain. So in other words, if you are actively involved in your stretches, then you are much less likely to cause a problem. So that if you're physio, so you've got a bent knee, you're a bit osteoporotic, you've got a nice bent knee and you're having stretches. So if I'm doing stretches on this bent knee, what I am doing is I am saying to you, I want you to kick your foot up in the air. Now, I'm not saying that you can do it, but this is what you should be trying to do. And as you're doing that, I should either be supporting your knee, supporting your foot, and you should be helping the work. You should be trying to lift. Now, one of the best ways of doing that is to put some support like a rolled towel or a pillow under your knee. What you're trying to do is lift your foot by pushing down on your knee. And what I am doing is I'm supporting your knee and I am feeling the amount of work and the amount of stretch. Now, what you need to know is that you should, in any condition, and this is so important, be able to feel how much stretch is there in the muscle. And I think any physiotherapist who has got any experience of stretches should be able to feel when you've come to that point where you can't get any further without some help. Now, there's two things that you can do on top of that. The first thing you can do is you can warm the muscles to relax them, either with hot packs. Try doing stretches in the bath. You can't do that with your physio unless you've got your cosy on, but you could do it in the bath with your partner or with your child, and you could try stretching your warmed limbs, because that'll make stretching less uncomfortable. Also, the weight of the water will help to support the limb. So you can do them in the bath if you still have a bath. You don't just have a walk-in shower. And the other thing that you can do is you can do what we call traction the joint. Now, you need to be careful when you're tractioning. And again, physio should be able to help you. And traction basically means stretch or pull. So that if you try to traction your own finger, what you're doing is you're pulling the joint surfaces apart. So to traction, you literally, and you can traction your joints purely by pulling them gently in a straight line. And you can do that with hips, and you can do that with knees. And you're not pulling hard, you're just pulling gently, and it's distracting the joint. It's pulling the joint surfaces apart, and that helps the joints and it helps the movement. And some of you may have even had neck traction. It's actually lovely when you have your neck traction. It's such a relaxing feeling when you get gentle neck traction. If any of you got really stiff shoulders or stiff muscles in your neck, then when you're lying, we do traction exercises for that as well. And that is a really nice way of stretching. And that's traction, but it has to be done gently, and it has to be done in the line of movement, and it has to be done with the help of someone who initially you can be taught, or your carer, or you can be taught. But certainly for adults, tractioning the joint is a nice way of increasing the movement, or initially getting more movement to start with. And that should not have any effect on osteoporosis if it's done correctly.
Okay. Someone else has asked that they have their main focus on getting treatment is to improve respiratory function. They use cough assist every day, and is that what it's called when you like breathe and breathe and breathe and breathe?
Oh,
is there any other stacking?
This breath stacking. There are lots of things you can do, and the first thing you can do is get a karaoke machine and sing, because singing is brilliant respiratory exercise, and people forget that. Just singing, go out and sing at the top of your voice. Singing is a wonderful exercise, and you can actually do singing lessons where you do breath control, so that singing actually, we've had I remember a young lady with type 3 who had spinal surgery, who then joined a choir. She was still ambulant even after spinal surgery. She joined a choir, and it actually helped her respiratory function by singing in a choir. I'm not saying that everybody should join a choir. I'm not saying that everybody has a good enough voice, but go and sing. That's a good one. You can play the recorder or any other blowing instrument. The recorder is probably one of the lightest ones. It's probably one of the least pleasant ones. But if your child has a recorder, or you've got one tucked away that you never got rid of when you left school, go and play the recorder. It's a horrible, ugly instrument. But I went out and bought my daughter something called a melodica, which is like a piano that you blow into. And it's got a keyboard, and you blow and you play it like a keyboard, and you could rest that down and actually blow into it, and it does come out almost sort of piano-like, but it's a lot nicer than a recorder. So that's a melodica. People of my age, which is ancient, may well remember having melodicas at school. As I say, I bought my daughter a melodica because she was quite interested in playing different musical instruments. You could get a kazoo. You can blow bubbles. The biggest problem we have at the hospital at the moment is it's very hard to blow bubbles with a mask on. So we're missing blowing bubbles, but certainly anything where you've got a blowing instrument. Now, most, as I say, blowing instruments, quite heavy, quite difficult. There's little ones. There are some of the ones like a clarinet. If you want to, a lot of people play piano with SMA. I know there's quite a lot of piano players out there, but certainly blowing instruments are a perfectly good way of doing it. There are games that we've talked about where you get straws, cotton wool balls, and you play blow football. You can play games where, don't forget, breathing is not only about out, it's about in. So breath stacking is in, cough assist is out. But the problem with some cough assist is it can be quite passive. So unless you're actually working with the machine, it can be quite passive. But blowing and sucking games, so you can do exactly the opposite with your cotton wool ball and your straw, where you're sucking and moving them from place to place. Have games where you've got not the little rice sweets, you know, those little ricey sweets that you can pick up pieces of popcorn and see if you can put them into a bowl. So get yourself a big bag of popcorn, spread it out all over the place, and then put it back in the bag, back in the box. That would take hours and hours, but it would be amazing respiratory exercise. Your cheeks would be sore afterwards. Don't forget, your cheeks can get sore from too much puffing and blowing.
I remember when I was a kid, I had something called blow pens.
Oh yes, blow pens.
Them and they'd spray the ink out and you
I'm
put
not sure if you can still get.
I don't know if they still sell them.
But you might be able to do that with liquid paint.
20 years ago. Yeah.
You might be able to do it with liquid paint, but just don't suck up too much. Otherwise you're going to have a beautiful mouth. Just suck up a little bit and then blow. But yes. But I remember blow pens. But I remember kids sucking as well and ending up with a face full of paint.
Oh, I don't think I ever did that. I don't think so. My mum would probably say I did. I don't remember doing it.
You can drop blobs of paint onto a piece of paper and then blow them and get this really nice drop effect by blowing on the paints. So there you are. You could have a really nice artistic thing where you're blowing on paint.
Okay. So the question is, how any exercises to strengthen wrists? I think they mean as in like this kind of.
There's loads and loads of things you can do to strengthen wrists. The first one, as I said, is get out the dough, get out the yeast and go and make bread, because anything where you've got to work your hands will work your wrists as well. People don't realize as soon as you make a fist, your wrist extends. Now, if you've been hanging your wrists down like that forever, it's really hard. But in the normal situation, as soon as you make a fist, your wrist pulls up backwards. So anything where you're squishing, squeezing, sponges, you will work your wrists as well. Now, your wrists work in more ways than just up and down. They work in and out as well. And many people's wrist will disappear off to the little finger side. So what you end up finding is that you disappear off to your little finger side and you end up with your hand twisted over, you know, almost like when they used to do the cartoons, when you would put lipstick on there and do cartoons with little eyes. But what you need to do is think that your wrists move in and out as well as up and down. They do have a little bit of rotation movement, but that's quite difficult to actually get. Now, the other thing, dare I say it, is screwing and unscrewing. You can get games where you have to screw and unscrew. There is a ball that you can get that vibrates that you can do exercise with. that's quite hard work. So be careful of those. But those little vibrating balls, those exercise balls that you can get for your hands. But to start with, get a flannel, squeezing, wringing out a flannel, wringing out sponges, kneading dough, Play-Doh, get the Play-Doh out and make models, get the Fimo out and make models. Anything where you're really squeezing hard is not just your hands, it's your wrists as well, but also all that screwing movement will also help. Those of you who know plaiting, do plaiting. Get your knitting needles out, girls or boys. Catherine Fassett was a man, is a man. If you actually see any of his work, it's very dramatic. Knitting, brilliant wrist exercise. Crochet, all sorts of things. Get your sewing needles out. Oh no, I can just see the faces. Woo, sewing, sew on some buttons. Get the kids sewing buttons, doing those little tapestries that we used to do. All good hand and wrist exercise.
Okay, I think that's the questions at the moment.
Okay, what I want to look at is the type 3s. What I want to talk about is the fact that while you're sitting there thinking, oh, I'm not eligible, there are a lot of people who are fighting for these drugs, but there's no point fighting for the drugs if you're going to sit there for the next year doing nothing. Let's start thinking about what we're going to do in the meantime while we're waiting. Because if you are not motivated now, then just having the drug is not going to change anything. So again, I know there are many, many adults with type 2 who are not yet getting any of these drugs. So to actually talk about the type 3s not being eligible is actually quite difficult because many of the type 2s aren't getting them either. Many centres aren't open. COVID has made a big difference to everything that's been going on. Very few new adults, or when I say new adults, very few adults have actually started on treatments during COVID. It's all got very much behind and it's causing big problems, I accept. So to a point, the non-ambulant 3s are no worse off at the moment than the type 2s who haven't got it. But then I put this question to the type 2s who want it and still haven't been able to access it. What are you doing to get yourselves into a position where you can maximize the effect of the drug? Now, I accept that no one will get physio while they're not getting the drug unless you decide to fall out of your wheelchair or fall out of bed and break a bone or something, or manage to get yourself into hospital with a chest infection. Please don't do that. But we know that therapy is just not there. But what are you thinking about? What are you actually doing now to prepare yourself? Are you having any stretches? Are you trying to roll yourself onto your tummy to get yourself a stretch? Do you have a standing frame in the corner that you don't use because, well, that just got boring? You need to think, what do I want from this drug? Is there anything I could be doing now? Could I be doing some exercises that will help once I do get the drug? Are there stretches I could be doing? Is there anything about my lifestyle that I could change to increase my activity or exercise levels? Could I do more in the kitchen? Could I do more activity? Sport is unfortunately not the option. The swimming has been a big, big issue because I know a lot of people who swam regularly have not been able to swim. It's really unfortunate that the one exercise that a lot of people could have benefited from is just not there. Now, I know many people weren't able to access hydrotherapy or swimming even before, but there are centres, and actually I know our hydrotherapy pool has reopened, so it is possible to get back in the water. I don't think there's many swimming pools have opened, but whether hydrotherapy pools have opened at the hospices, whether anybody has access to hydrotherapy. One of the big issues with hydrotherapy is there is no point in me writing letters saying this child, this person needs hydrotherapy, because there are just not that many facilities around. And not only are there not that many facilities, People are not going to staff hydrotherapy pools. People are not going to build hydrotherapy pools. They are very, very expensive. And they're not only expensive to build, they're expensive to maintain, and they're expensive to staff, because you need a minimum of 2 staff there. And in most hydrotherapy pools, there's a minimum of 3. So hydrotherapy is a very, very expensive form of treatment. And I don't think people realize just how few facilities do have hydrotherapy. And even when they're there, they're not used well. A lot of the special schools have got hydrotherapy pools, but they don't use them at the evenings and weekends, which is always a big shame. The hospices are finding difficulties in staffing their pools, but whether they're allowing people into the pools is hard to know. But it's certainly one of the best exercises. If you're osteoporotic, that is one exercise you could be doing, is hydrotherapy. But in the absence of hydrotherapy, then you need to look at local swimming pools. Now, a lot of people will say they're too cold. There is no reason why you should not swim in a full body suit. It's not like a diving suit, but these are the sun suits. These are very often the ones that the ladies wear. Some of the Muslim ladies will wear them, that cover them from top to bottom. They are much warmer than going in the water in a cozy. And there is no reason at all why you shouldn't have a full body suit. They're very easily accessed on the internet these days. They're not particularly expensive. And they're obviously much, much warmer than getting in the water with just a cozy or a pair of swimming trunks on. So cold in the water is not necessarily the biggest issue. Cold in the water can be a problem of just not moving around enough. And if you've got someone with you in the water, make sure they are getting you moving a lot and keep you warm in the water. And once you get warm in the water, the problem then becomes getting cold coming out of the water. And often it's the changing rooms in swimming pools that are so cold. And that's something that you need to discuss with your local swimming pool, because the changing rooms probably need to be warmer, and particularly the special changing rooms need to be warmer. Now, a lot of parents complain that the swimming pools are accessible and they have a hoist and you can get in the water, but the changing areas are not accessible and they don't have hoists and they don't have good changing beds, and you end up in a family changing room, but it's not useful. It really isn't useful if they don't have hoists and everything in there. Now, there are many organizations, Trailblazers is one of them. If you're having trouble with your local authority at getting that, they are obliged to make those facilities. That is all about access and disability access. No good just having the hoist into the water if you haven't got a hoist in the changing rooms. So it's a bit like the accessible toilets that now all have hoists in. They need exactly the same sort of changing room with hoists and facilities so that you can get dry in the warm as quickly as possible and as easily as possible. And they should be accessible for adults. I know there is nothing worse than going swimming, getting in the water, getting changed, all the palaver for half an hour in the water, and as much fun and as much exercise as it may be. It's a 3-hour job to have half an hour in the water. And that is a big, big issue. I appreciate this is not the climate for a lot of outdoor pools. I know a lot of people who are now getting hot tubs, but you need to make sure you can get in and out of the hot tubs as well, that they are accessible, because one of the big problems with hot tubs is getting in and out. It's also getting disgustingly cold outside, and while the water's warm, it is not only cold, but it's pretty breezy, so you're going to end up with a hot tub full of leaves and gunk. And they're not the cheapest thing in the world to keep warm. So you need to be aware of that. But it is very unfortunate that a lot of the sports, even the horse riding, has not been going on during COVID. So it's been a very, very difficult time. There is no doubting that we're going to have to use our imagination more. and try a lot more activity and exercise at home. Any more questions, Marnie?
We have a few. I'll just mention before I say, when I went swimming before, they used to let me get changed in the first aid room because it was very, very warm and it had a plinth. So if you are struggling, it's if you can use the first aid room to change in until they can sort the facilities out. Just thought I'd add that in as a bit of advice.
No, that sounds great, Marnie.
We've got a question. How do you get a referral for hydro?
Well, firstly, you've got to find out whether there's hydrotherapy facilities in the area. There's no point in having a referral for hydro if it doesn't exist. And this is one of the big complaints from local therapy services. It's no good your GP or your consultant or your neuromuscular physio asking local for hydro for a patient where hydro doesn't exist. If there's no hydrotherapy facilities, you ain't going to get it. So that's the first thing you have to consider. Are there hydrotherapy facilities in your area? The other thing is it's really difficult to refer for hydro. You need to have a referral for physio. You try and get your GP to agree to that, or your local adult neurologist or pediatrician. Now, if the facilities are there, that's fine, but most physios will say that you can only have a block because the demands on hydrotherapy are always very great. So you will likely get a 6-week block. Some people are lucky, get 6 weeks on, 6 weeks off. Some people get 6 weeks in a year and that's your lot. And if you miss any, they don't make it up at the end. You know, if you're sick one day or you just can't make it because you've got the wheelchair people coming around or something else, you lose that slot. The other thing is, how do you get that referral? What means that you could have hydrotherapy over physiotherapy or anything else? The first one is definitely the osteoporosis. That is a good reason for needing hydrotherapy, because if you are very osteoporotic, you can obviously move around and work in the water much better than you can work in most other places. If you have just had spinal surgery and you are feeling that you've lost a lot of power through having been immobilized or not being so active, then you could possibly have a block of hydrotherapy post-spinal surgery. And certainly for a full fusion, not magic rods, but for a full fusion, as soon as the surgeons let you back in the water, if you're an ambulant type 3 who's had spinal surgery, and there are ambulant type 3s who have spinal surgery, then for undoubtedly the best place you can exercise is back in the water. Best place to get you back on your feet is in the water. So there are certainly very, very good justifications for having hydrotherapy. But if the pools are not there, you can't have hydro. And that is one of the problems. There are centres. I know in London, there's one called Aspire, which is in North London, in Stanmore. They have a very accessible pool and accessible facilities, and you can be referred there. But actually getting a referral for hydrotherapy will depend on your local services. Now, I know that there are adult neurologists who work in hospitals where there are hydrotherapy pools. A lot of them seem reluctant to refer for hydro, whether they have been told that, you know, don't bother referring because the patients won't get. I don't know what the criteria are for adults. I know the main criteria for children is just literally having the pools around.
Okay. Someone's asked, is there a resource when find exercises to do if we can't get a hydro referral so that we can do them ourselves in a pool?
I am not aware of SMA exercises that are available unless there are any online. I know I was working with some Duchenne charities on doing some exercises. There are certainly hydrotherapy exercises online, but what I will do, Marnie, is I will look up what is out there for hydrotherapy in terms of exercise, and I will give them back to TreatSMA and see what we can do. There are resources, hydro resources, and I will certainly try and sort those out.
Great. Someone's asked, is it worth investing in a hot tub or a jacuzzi in order to do exercises in at home?
I think the best people to answer that question would be people who already have a hot tub or a jacuzzi. My honest feeling is you don't need the bubbles. The bubbles are very nice, but they don't make a lot of difference. So you don't actually need the bubbles unless you particularly like the bubbles. The most important thing about the hot tub is that you have room to move. If it's too short or too shallow, then you're not going to have room to move. The question as to whether it's worth investing in it, I think most people who have invested in a hot tub have found them very useful. It has surprised me that a couple of families have said, oh, they used it once a week. That was motivation, I reckon, because if the hot tub's there and it's being kept heated, it seems that it's a brilliant place to do exercise. I have been in a hot tubs. I would certainly say it is a lovely place to exercise. It warms your muscles, which always helps. So it makes stretches easier. If it's big enough for a couple of people, so somebody can come in and do your stretches with you, that's a lovely way of doing it. If somebody can get in the hot tub with you and do resisted exercises, that's an excellent way of doing exercising. Yes, the jets are good to work against. That's not bubbles, that's jets, because the bubbles themselves are not always strong enough to work against. But certainly, I can't say it is worth investing in. I certainly think it's a nice idea. As I say, the best people to say whether it's worth investing and the sort of size that you would need are the people who've actually got them. But I think I don't know anybody has ever said to me that they regretted having got one. But that might be a nice
I had a hot tub.
topic. Sorry, Marnie, that might just be a nice one to put on Facebook on one of the groups and say, what do people think about their hot tubs?
Yeah, I mean, I had one growing up. I found it really relaxing. I always used to sleep well after being in it. I think I was just so relaxed after it. I think more time than not when I was in it, it was me and my sister playing rather than using it for actual physio. But I can't say it was, we used it all the time. It was brilliant. And then the rats ate the wires and we couldn't use it. So if you
Fried
get one,
rats. I think that you missed an important point there though, Marnie, that you said you were playing in it. The play itself would have been exercise, because sitting in your wheelchair compared to what you were doing in the water was a lot less active. So while you say you were playing in it, not doing exercise, the play itself was exercise. You were moving so much more than you would have done just sitting in your wheelchair. So never think that sort of play is not exercise. Play is exercise, except on an Xbox or a PlayStation. Don't give me those as play. But if you are actively playing, that is exercise.
Yeah, that's true. We've got someone who's jumped onto the questions. The topic's kind of just been covering, so I'll do this quickly because it's getting a bit late. Can you use CAFOs or those kind of leg supports or gaiters in a pool to give you more support so you can walk in the pool?
Yes, but I wouldn't use CAFOs because they'll rust. I must admit, we have had children who've used their old CAFOs in the pool, so they've kept their last pair and used those in the water. You could use gaiters, but again, you need to make sure they won't rust. We have made plastic splints for people in the past. There are thermoplastic splints that you can make. Scotch cast, which is fiberglass, you can use in the water. So if you've got somebody who will make you fiberglass splints, then yes, you can definitely use fiberglass in the water. They need to be bandaged on, so of course everything gets wet. But what you do is you make the fiberglass casts, you pad them, but then you strip the padding out and you line them with material that, yes, as I say, will get wet in the water, but that's not the main thing, because you'll just then stick them somewhere where they'll dry out. But CAFOs, I wouldn't use a good pair of CAFOs in the water. They'll rust and do all sorts of nasty things. But as I say, I have had kids who've used their old CAFOs. Gaiters, I'm not sure if gaiters rust. In theory, they shouldn't. There are some gaiters where the struts are a heavy plastic, and then they would be absolutely fine in the water. Again, it would just be a case of drying them out afterwards. Or you can have plastic, thermoplastic, because you certainly can have thermoplastic splints. Beware that the thermoplastic splints aren't those that just melt in hot water, because you might find them melting as you get in the hot tub or the pool. But there are thermoplastics that once you've molded them in very, very hot water, can't be changed, so they're set. Or as I say, you can certainly do a Scotch cast, and we have made Scotch cast for kids in our pool before. We've made Scotch cast splints for them to use in the water. Like, just make a cylinder, chop it up, and then bandage it back on in the water to help stand.
Okay, we've got someone who's just asked that they're hoping to be able to go horse riding when they can. Should their child wear a spinal jacket whilst horse riding?
That really depends on two things. Firstly, the riding school, because it will depend on the saddle and whether the jacket and the saddle are appropriate together. Because some of the saddles that come up quite high, it may be that firstly it's difficult to get onto the horse with the jacket on, and the jacket and the saddle may not go together. So you may have to ask the advice of the people at the riding school. The other thing is, my honest feeling is, if the child does not need the jacket to sit, so in other words, it's just for posture. If a child cannot sit without the jacket, then they're not going to sit on a horse without the jacket. If the child can sit, then they will get more exercise out of the jacket than they will in the jacket. So my feeling would be, if the child is using it for posture and their posture is not severe so that it would pull them to one side where they'd fall out of the saddle, then yes, I would be tempted to say that you will get more exercise out of the jacket. But that is quite individual, and without knowing the child, that would be hard to say. But you'll need to discuss it with the riding school, because as I say, it's got the jacket and the saddle have got to be compatible, and getting them onto the horse is more difficult with the jacket on than the jacket off. I think you might have frozen Marnie. So I'm not sure where we're going, because we seem to have lost Marnie. So we will talk also about the idea of some aims. Where have we got to? We're still going. So aims, one of the things I want to go back to is this idea of setting yourself some goals and some aims. And you really do need to start thinking whether you're on treatment or not on treatment, whether you're type 2 or type 3, about what you want these drugs to help you achieve. Marnie's just sending me a message. Internet's gone off. Okay, so we'll keep going for a while. Let's go for a couple of more minutes. We need to actually start writing down what you think you want to achieve. I was speaking to somebody recently about an adult with type 3 who hasn't exercised for quite a long time, but would like to access the drugs when they become available. The top and bottom of that is, if you have not exercised for a long time, I accept it will stop deterioration, but is that all you want from the drugs? Are you just hoping to stop deterioration? Now, obviously, if you are losing arm power, if you are getting more respiratory problems, if your head control is deteriorating, then yes, these drugs will help with that. But you may want to think, are there other things I want to be able to do? I can still feed myself, but if I were to lose that, how would I feel? And you need to think, should I be exercising now? Should I be making some effort now? Should I be trying to activate my muscles now? Should I be thinking of some goals that I want to achieve with the help of these drugs? Because it's not just about staying the same. It's about regaining some skills. As Marnie said, it's about rehabilitation. Do we want to be able to roll over in bed? Do we want to help our partners, our parents, our spouses to actually be able to do more for ourselves? So that we need to think now, we want to exercise, we want to actually be able to do something effective around and about. Do we want to be more healthy? And it's not just a case of being our respiratory being better, our head control being better, not losing. But actually, exercise is more than just what it stops you losing. It's also about how it makes you feel, about the endorphins that you release from doing the exercise, how much better it is generally for your heart. Now, I know the heart is not affected in SMA, but the fact that you have SMA does not mean that you can't get problems of adults from lack of exercise, overweight, all the things that other adults are going to experience as they get older. So it's about being healthier. It's about being more active. It's about using these drugs to have a healthier lifestyle. And this is something we need to think about. It is not just about having the drugs and stopping the deterioration. So unfortunately, Marnie's lost her internet. I don't know if there's any more questions, unless I can get them on chat, but I'm not sure that I can. I don't think I get to see the chat that Marnie gets as host. Can I see it? No, I can't see what Marnie can see. So unfortunately, I can't take the rest of the questions. What I will do is I will get Marnie to email them to me, and if we can reply to people, then we will. So keep sending your questions. We will answer them as soon as possible, and hopefully we will be back with another Zoom soon. So get exercising, people, every day. It's useful for health. I am happy to take individual questions and see what we can do. We will get some hydro ideas together of what you can be doing. But one of the things you need to think about in terms of in the pool, and one of the reasons where it might be nice to try and at least get yourself one session in the hydro pool. We try and get all our kids in the pool who've never been in the pool, just to show parents what to do. Because what you need to know is not only getting in the pool, but what equipment you might need, what flotation equipment works best for you. Not everything works exactly the same for everybody. Some people are happy just with a neck ring, other people are not. Some people are happy with woggles under their neck and under their body. Some want much more support. So one of the important things is, if you can get access to a pool at least once with a physio or a swimming trainer or somebody to help you, just to be able to know what equipment you will need to help you do your exercises on your own. So one session would be really, really helpful. But give me a shout if there's any more we can help you with, and hopefully we will see you soon. Bye.